In orthopedics, medical diagnosis carries this expectation of just like absolute precision.
Oh, sure.
Like you look at an x-ray, you see that jagged white line, and the attending physician just points at it and says, there it is, broken bone, fix it.
Right. It's totally binary.
Exactly. It's binary. But as a first-year medical student stepping into the world of infectious disease and pharmacology, you are about to find out that the x-ray machine is, well, kind of useless here.
Yeah, pretty much.
We are looking at a diagnostic landscape that is entirely murky.
It really is. I mean, it's the definition of diagnostic muddy waters.
Right.
Because you're fighting an aggressive, rapidly replicating enemy that you literally cannot see.
Right.
And, the clinical clock is ticking very loudly the whole time.
And that is exactly why we're doing this deep dive today. We're taking you straight to the emergency room to master the clinical application of antibiotics in the treatment of urinary tract infections.
Yeah, we aren't going to just read you a pharmacology syllabus.
No, please no.
Right. We're taking the clinical guidelines, the diagnostic slides, the up-to-date algorithms, and we're running them all through a real-world scenario.
Because, knowledge is only valuable when you actually understand how to apply it at the bedside.
Exactly. So we are going to follow a recent clinical case. Let's meet Emily. She's a 34-year-old school teacher.
Okay.
And by following her journey, you're going to learn the complete clinical synthesis arc.
Which means, like, understanding initial broad-spectrum empiric drug therapy, the biology of culture testing.
Right. Reading an antibiogram.
Yes.
Yeah.
And that crucial final pivot to a narrow-spectrum targeted antibiotic.
Okay, let's unpack this. We start in the ER.
Right. Hour zero.
Exactly.
Yeah.
So Emily comes through the doors, and she looks incredibly toxic. She presents with a fever of 101.5 degrees Fahrenheit.
Oh, wow. Okay.
Yeah, which blows right past that 99.9-degree threshold we usually watch for. And she's experiencing rigors.
Those are those intense, like, uncontrollable shaking chills, right?
Yeah, exactly. It tells you her body's thermoregulatory center is reacting to something severe.
Okay, so she's really sick.
Very. And along with that systemic response, her physical exam is highly specific. She has severe flank pain and marked costovertebral angle, or CVA, tenderness.
So when the physician taps on her back.
Right, percusses right over the kidneys.
Yeah.
The pain is just intense. And this is all layered on top of the classic lower urinary tract symptoms, right? Dysuria, which is painful urination, and a high frequency of urination.
But wait, if she has, painful urination and frequency, the natural instinct is to just think, oh, this is a standard UTI.
Sure. Yeah.
I mean, she's a young, otherwise healthy woman. Why are the alarm bells ringing so loudly here? Like, why not just write a prescription for some oral pills and send her home to rest?
Well, the alarm bells are ringing because the anatomy of the infection has fundamentally changed.
How so?
What you're describing as a standard UTI is what we formally classify as acute simple cystitis. That's an infection completely localized to the mucosal lining of the bladder. The symptoms there are irritating, sure, dysuria, frequency, maybe some suprapubic pressure, but they aren't systemic.
Right. The body isn't mounting this, like, massive full-body inflammatory response.
Correct. But the moment you observe a fever of 101.5, those rigors, and that CVA tenderness, the diagnosis violently shifts.
It becomes an acute, complicated UTI.
Exactly. Specifically, pyelonephritis. The bacteria haven't just colonized the bladder anymore. They've ascended the ureters and physically invaded the renal parenchyma.
Which is the actual kidney tissue itself.
Right. And the kidneys process massive amounts of blood flow.
Oh, right. Because they're constantly filtering.
Which is the terrifying part.
Yeah.
Because the infection is now seated in this highly vascularized organ. The risk of that bacteria crossing over into Emily's bloodstream and triggering life-threatening sepsis
is huge.
It's a very real, immediate clinical threat. Emily fits the pyelonephritis profile perfectly. We have to move fast.
So the pressure is really on. I mean, as a new medical student, or even just as a human looking at a patient who's shivering and in so much pain, the overwhelming psychological urge is to just fix it instantly.
Naturally, yeah. You want to do something.
You want to grab the strongest IV antibiotic in the Pyxis machine, hang the bag, and just flood her system to kill the bacteria.
But doing that violates one of the strictest laws in infectious disease medicine, the minute zero rule.
Right, the minute zero rule. Tell us about that.
So the clinical rule of minute zero dictates diagnostics before therapeutics.
Okay.
Before a single drop of any antibiotic enters Emily's veins, you have a rigid mandate. Cultures first.
So the nursing staff has to immediately draw blood specimens for blood cultures.
Yeah, and collect a clean catch urine specimen.
Yeah.
You do not cross the line to initiate IV antibiotics until those samples are physically secured.
Okay. I understand the theory behind getting a sample, but I kind of want to push back on the clinical reality of this.
Okay, go ahead.
If a patient is actively declining, right, and every hour counts, aren't we actively delaying her treatment just to satisfy, like, a lab requirement?
It feels like that, but what's fascinating here is how incredibly lethal these antibiotics are, and how that lethality can actually blind us if we deploy them prematurely.
Blind us how?
Well, if you push a heavy-hitting IV antibiotic into Emily's arm before drawing those cultures, that drug will circulate systemically in minutes. It's going to begin lysing or bursting the bacteria in her blood and urine almost instantly.
Which to the patient feels like a win, right? The bacteria are dying.
It's a short-term clinical win, yeah, but it's a long-term diagnostic disaster. Doing that reduces our pathogen detection rates in the lab by up to 50%.
Wow, half of them just won't show up.
Right. Because when the lab plates that blood sample on an agar dish, they need viable, intact bacteria to multiply so they can identify the species and figure out what kills it.
Ah, I see.
If the antibiotic is already in the blood when you drew it, nothing's going to grow. You get a false negative.
And suddenly you're trying to fight an invisible enemy without a map. Like, you know there is an infection, but you have zero data on what it is or what it might be resistant to.
And you'll be flying blind for the rest of her hospital stay. If she suddenly deteriorates on, say, day 3, you have no microbiological data to guide your next move.
That's terrifying.
It is. So my clinical mantra for you to carry into your residencies is this: we cannot target what we cannot grow.
We cannot target what we cannot grow. That paints such a clear picture of the stakes here. Okay, so the phlebotomist gets the blood, the urine sample is collected, and they are rushed off to the lab to incubate.
Right. Minute 0 is officially complete.
The suspect's DNA is at the crime lab, but the lab needs time, and Emily needs help right now.
Yeah, this is the agonizing wait. The cultures are incubating, but bacterial replication takes time. It'll take 24 to 72 hours for the lab to grow the organisms, identify the species, and test their drug susceptibilities.
And Emily is sick today.
Exactly. We have to intervene immediately.
Which means we have to make an educated guess. This brings us to the concept of empiric therapy.
Right.
We can't know for sure what's attacking her, so we use statistical probability, the patient's specific variables, and local epidemiological resistance data.
Right, to choose a weapon that will cast a wide enough net to catch the most likely culprits.
Okay, so let's run Emily's clinical variables. She requires hospitalization for IV fluids and monitoring, but she is non-critically ill. She's not in septic shock.
Right, she's stable.
Mm-hmm.
And crucially, looking at her chart, she has 0 risk factors for multi-drug resistant organisms.
So no recent hospitalizations?
Nope. She hasn't been on prolonged broad-spectrum antibiotics, and she hasn't traveled to areas with high endemic resistance.
Okay, so we're likely dealing with a standard community-acquired pathogen. Based on the ID guidelines for this specific presentation, the empiric best guess is an intravenous drug called ceftriaxone.
Usually dosed at 1 to 2 grams daily, yeah.
Right.
That is the gold standard empiric choice here.
But let's dig into the pharmacology of why we're using 5-ceftriaxone. Because if someone hears UTI, even a severe one, the drugs that immediately come to mind are the classic oral medications, right? Like nitrofurantoin or fosfomycin.
Oh, absolutely. Millions of prescriptions are written for those.
So why are they completely off the table for Emily?
That comes down to pharmacokinetics, which is basically how the human body moves and processes a drug. Medications like nitrofurantoin are incredibly effective for acute simple cystitis because of how the kidneys handle them.
Which is how?
The kidneys filter nitrofurantoin out of the blood and dump it into the urine so rapidly that the drug never achieves meaningful concentrations in the bloodstream or in the renal tissue itself.
Oh, wow. So it just bypasses the kidney meat entirely.
Exactly. It all ends up pooling in the bladder.
So if the infection is in the bladder fluid, nitrofurantoin is basically a localized nuclear bomb.
Right. But for Emily, the infection isn't just in the fluid. It's invaded the meat of the kidney, the renal parenchyma.
Okay, so since nitrofurantoin flashes right through that tissue without accumulating, it would do absolutely nothing to cure her pyelonephritis.
Nothing at all. We need a drug that profoundly penetrates and saturates the systemic tissues. Ceftriaxone, which is a third-generation cephalosporin, does exactly that.
And it provides a broad enough spectrum to eradicate the gram-negative pathogens that overwhelmingly cause pyelonephritis, right? Usually E. coli.
Yep, it covers the likely bases without going overboard.
Right, because we aren't bringing out the absolute strongest drugs we have, like the carbapenems.
No, we need to save those for proven resistant superbugs. Antibiotic stewardship starts on day 1.
So ceftriaxone is the chosen weapon. Let's talk about the microscopic battlefield now. How does this drug actually kill the E. coli once it saturates that kidney tissue?
Well, to understand the mechanism, we really have to look at bacterial anatomy. Bacteria operate under massive internal osmotic pressure.
Like a balloon.
Yes. If you just dropped a bacterial membrane into a normal environment, the internal pressure would cause it to swell and pop. So to survive, they surround themselves with a rigid, highly structured cell wall made of peptidoglycan.
They basically wear a microscopic suit of armor to keep themselves from exploding.
And that armor requires constant maintenance. The bacteria use specific enzymes called transpeptidases to constantly cross-link the peptidoglycan strands.
Like weaving them together?
Exactly, locking them together for structural integrity. In pharmacology, we refer to these transpeptidase enzymes as penicillin-binding proteins, or PBPs.
Okay, PBPs. So if the bacteria are constantly laying down peptidoglycan to build this wall, the PBPs are essentially the bricklayers?
Oh, that's an excellent way to visualize it. Yes, the PBPs are the bricklayers. They're out there spreading the mortar and stacking the bricks to keep the wall from collapsing under the pressure.
Okay, so where does ceftriaxone come in?
Now, ceftriaxone belongs to a massive class of drugs called beta-lactam antibiotics. The defining feature of these drugs is a very specific four-membered chemical ring, the beta-lactam ring.
So when the IV ceftriaxone floods Emily's kidney tissue, it's sending millions of these beta-lactam molecules to the site of the infection.
Right, and the drug acts like a saboteur.
A saboteur.
Precisely. The beta-lactam ring structurally mimics the natural building blocks the bricklayers usually use. So the PBP enzyme accidentally grabs the ceftriaxone molecule, and the beta-lactam ring permanently binds to the enzyme's active site.
Oh, wow. So the bricklayer is just totally incapacitated?
Totally. The cross-linking completely stops.
But the bacteria is still metabolizing, still trying to grow, right?
Yeah.
The internal pressure keeps building, the wall gets weaker and weaker without the bricklayers to maintain it, and
The
eventually...
bacterial cell simply ruptures, it lyses, the cell wall fails, and the bacteria dies.
Man, that's brutal, but effective. So we hang the IV bag, saboteurs go to work, and Emily finally starts getting targeted help.
Yes, she does.
But, bacteria have been evolving for billions of years. They don't just surrender.
No, they certainly do not.
The ceftriaxone is in her system.
Yeah.
We still don't know exactly what we're fighting. Let's move the timeline forward. It's been 24 hours since the ER.
Okay.
Emily is resting, and the lab calls down to the floor with our very first piece of microbiological data.
Right, so the cultures haven't fully grown yet, obviously, but the lab has enough biological material to perform a gram stain.
Okay.
They look at the slide under the microscope and report back two words, gram-negative bacilli, or gram-negative rods.
Okay, when you're sitting at the nurse's station and you get that gram stain report at hour 24, how does that fundamentally change your clinical calculus?
It brings a massive wave of relief, honestly, because it immediately validates our empiric choice.
Because of the cell wall structure.
Exactly. Gram staining differentiates bacteria based on the architecture of that cell wall we just talked about. Gram-negative bacteria have a thinner peptidoglycan layer hidden beneath an extra outer lipid membrane, which causes them to stain pink instead of purple.
Which instantly eliminates all gram-positive organisms from our differential diagnosis.
Yep. We know for a fact we aren't dealing with Staphylococcus aureus, so we don't need to panic about MRSA. We aren't dealing with Enterococci.
It cuts the suspect list in half.
And finding gram-negative bacilli points a massive neon sign directly at the Enterobacterales family.
Which includes E. coli, Klebsiella, and Proteus.
Right. And these are the exact pathogens ceftriaxone is designed to destroy. The lab data confirms our blind guess was highly accurate.
That's the best feeling. But let's pause and look at the alternative.
Uh-oh.
Because medical students aren't just tested on the happy paths, they are tested on the disaster.
That is very true.
What if Emily's infection wasn't a standard susceptible E. coli? What if she started spiking a higher fever on day 2, her blood pressure dropped, and it became clear the empiric ceftriaxone was completely failing?
Okay, if the empiric therapy fails, despite the gram stain pointing to a gram-negative rod, we have to assume the bacteria has deployed a countermeasure.
A countermeasure, like
The
what?
most prominent threat in this exact scenario is a mechanism known as ESBLs, extended spectrum beta-lactamases.
Right, we know bacteria can share genetic material through horizontal gene transfer, like passing around plasmids, like trading cards.
Exactly.
If a bacteria acquires the genetic code for an ESBL, what is it actually doing to the drug?
Well, the plasmid teaches the bacteria how to manufacture its own biological weapon, an enzyme called a beta-lactamase. And these are extended spectrum, meaning they've evolved to recognize and destroy not just early penicillins, but advanced third-generation cephalosporins.
Including our ceftriaxone.
Yep. So the bacteria pumps these ESBL enzymes out into the surrounding environment. They act like chemical scissors.
Oh man, so they find the ceftriaxone molecules.
Chemically cleave open that crucial four-membered beta-lactam ring and hydrolyze the drug.
So the drug is rendered completely inert.
Completely. The saboteur is assassinated before it ever reaches the bricklayer.
Wow.
The bacteria continues building its wall completely unimpeded, and the infection rages on while the patient crashes.
Okay, so if we discover the ceftriaxone is being chewed up by ESBLs, we have to pivot to the heavy artillery. You mentioned earlier we keep certain ultra-broad drugs in reserve for exactly this scenario.
Right. We would immediately escalate her therapy to the carbapenems, drugs like meropenem or ertapenem.
But wait, if carbapenems are also beta-lactam antibiotics, meaning they rely on that same chemical ring to kill the bacteria, why don't the ESBL enzymes just chop them up too?
It is a brilliant piece of physical chemistry.
Uh,
Carbapenems possess a unique structural armor. They alter their 3D geometry.
oh.
Specifically, they utilize a trans-conformation of their 6-hydroxylethyl side chain, and on their core thiazolal ring, they substitute a single sulfur atom for a carbon atom.
Wait, they just swap one atom. So by swapping out one atom and slightly shifting the angle of a side chain, the physical shape of the molecule changes just enough to create steric hindrance.
Exactly. The ESBL enzyme physically cannot fit its active site around the carbapenem molecule to cut it.
That's wild.
The drug is structurally stable against ESBL cleavage. It wades right through the cloud of enemy enzymes, binds to the PBPs, and successfully halts cell wall synthesis.
A microscopic structural shift saves the patient's life. It is incredible.
Surely.
But, all right, let's pull back from the hypothetical resistance nightmare and return to Emily's actual clinical arc.
Right, Emily.
She has been on IV ceftriaxone. We are now at hour 72.
The defining moment of the admission. The complete culture and sensitivity report, the antibiogram, is finally published by the lab.
So we are no longer guessing based on probabilities.
No, we have absolute biological certainty.
The report explicitly identifies the organism, Escherichia coli. The colony count is massive, greater than 100,000 colony-forming units per milliliter.
Very definitive.
And beneath that identification is the sensitivity panel, showing exactly what kills this specific strain.
The lab has exposed Emily's E. coli to various antibiotics to determine the minimum inhibitory concentration, or MIC. It gives us a map of resistance and susceptibility.
Looking at the panel, it marks ampicillin with a capital R for resistant, so that drug would be useless.
Right.
But it shows a capital S for susceptible next to ceftriaxone, as well as oral options like ciprofloxacin and levofloxacin.
This is the best-case scenario.
Oh.
It means our minute zero blood draws successfully captured the pathogen, and our hour one empiric guess of ceftriaxone was perfectly matched to the bug. The drug is actively working.
Which brings up a massive point of confusion for a lot of students.
Oh, I bet I know what it is.
If Emily has been on IV ceftriaxone for 3 days, her fever has broken, her flank pain is receding, and the lab literally just proved the drug kills the bacteria.
Why on earth would we stop giving it to her?
Yes. The instinct is to keep the IV running until she's totally cured.
That instinct makes intuitive sense, but in modern infectious disease practice, it is completely wrong. This brings us to the critical final phase of the clinical synthesis arc. The pivot. We also call this directed therapy or step-down therapy.
We step down from the eye.
We do. The clinical rule is absolute. Once the antibiogram confirms susceptibility and the patient's clinical markers like the rigors, fever, and leukocytosis have stabilized, we must pivot.
Wow.
We discontinue the broad-spectrum IV therapy, pull the line, and transitioned her to a narrower spectrum, highly bioavailable oral agent to finish out the 5 to 7 day treatment course.
Like the ciprofloxacin or levofloxacin that showed up as susceptible on her lab report.
Exactly.
Those are oral fluoroquinolones that have excellent systemic tissue penetration. But why force the change? Like the IV is working.
We pivot for 3 vital reasons.
Oh.
First, maintaining an indwelling intravenous line carries a daily compounding risk of hospital-acquired complications.
Like infection.
Right? Every day that catheter sits in her vein is another chance for phlebitis or a secondary bloodstream infection. Second, transitioning to a highly bioavailable oral pill allows us to safely discharge Emily. She can finish her recovery in her own bed, and we free up an acute care hospital bed for a critical patient.
That makes total sense. And the third reason?
The third reason is the bedrock of antibiotic stewardship. Ceftriaxone is a broad-spectrum weapon. It is effectively a shotgun.
Oh, right.
Yes, it's killing the invasive E. coli in her kidneys, but it's also circulating through her GI tract and indiscriminately slaughtering the healthy protective microbiome in her gut.
Which opens the door for opportunistic superinfections like Clostridioides difficile or C. diff.
Yeah, and a C. diff infection can be more dangerous than the original pyelonephritis. By stepping down to a targeted oral agent, we switch from a shotgun to a sniper rifle.
Nice.
We finish off the E. coli, limit the collateral damage to her gut flora, and we actively combat global antibiotic resistance by strictly limiting the amount of broad-spectrum drugs we pump into the environment.
Okay, let's synthesize this entire journey because this really has been a masterclass in clinical application.
Lab to do it.
For you listening, preparing for the wards, Emily's case is the blueprint. The clinical arc demands that we act on probability during empiric therapy, making our best, safest guess at hour 1 while adhering strictly to the minute 0 mandate of cultures first.
And the moment we hit hour 72, we abandon probability for certainty. We analyze the antibiogram, we step down the therapy to minimize collateral damage, and we practice targeted directed therapy.
We moved from the terrifying ER presentation to the diagnostic discipline of minute 0 to the pharmacological saboteurs of hour 1.
To the genetic realities of hour 24.
And finally, the stewardship of the hour 72 pivot.
It is a deeply logical, beautiful algorithm when executed correctly. It cures the patient in front of you while protecting the efficacy of our medical arsenal for the patients of tomorrow.
And speaking of the patients of tomorrow, as we wrap up this deep dive, we want to leave you with a final thought to mull over before your next pharmacology lecture. We explored how bacteria use distinct evolutionary strategies to survive.
Right, we see pathogens using horizontal gene transfer to acquire specific defenses. We've seen how MRSA acquires the mechabine to fundamentally alter the structure of its penicillin-binding proteins.
Changing the target site so the saboteur can't bind.
Exactly. And today we explored how E. coli produces ESBLs to enzymatically hunt and destroy the drugs before they can even act.
Altering the target or destroying the weapon. Two radically different, highly effective survival strategies.
So imagine the ultimate evolutionary convergence. If a future highly virulent superbug successfully synthesizes both mechanisms, if it structurally mutates its cellular target while simultaneously deploying broad-spectrum destructive enzymes into its environment.
Oh, man.
How will your generation of physicians have to adapt the minute 0 protocol and rethink our best guess empiric strategies to save the Emilys of the future?
It's a daunting question, but after walking through the clinical arc today, you are one step closer to being the physician who figures it out. Keep analyzing, keep questioning the mechanics, and we will catch you on the next deep dive.